and it is May 21, 2021. We're getting ready to perform live spine surgery on a patient who is visiting us from Canada for the endoscopic Deuk Laser Disc Repair procedure. Now, she's had back pain for years. I want to say 8 years. Memory serves me correctly. Is that right? 8 years? Huh? Yes. All right. And she comes here because there's nobody in Canada or anywhere else in the United States able to fix her back pain. So she wants it fixed endoscopically. This is the only place in the world to get endoscopic surgery, as opposed to open surgery, which is done with lots of big incisions and bleeding and scarring and all kinds of nastiness. So she's watched the surgery. This is my hand. I'm going to give you some numbing medicine, okay, to get started. You might feel a little stick and some burning. That's normal. Don't be upset. I'll let you know how everything's going, if there's a problem or if everything's going well, okay? Important that you just lay still and let us do what we need to do so we can get this done. And when you wake up, we'll be done, and I think you'll be very happy with the results. I need you awake in the beginning to help me. All right. You've had pain for 8 years? Shot? Please flip that image. I don't know why you have the left on the right and the right on the left. All right, let's go to a lateral view, please. So I'll be talking to my team, and you'll hear me talking to them. Sometimes I'll ask you a question, all right? But if you have pain, just say ouch, and tell us if it's in your back or down your leg. Back or leg. All right. Not bad. So you can see that's the L5-S1 disc. It's very collapsed. She has what's called degenerative disc disease. Shot. A little uncomfortable there? All right. Shot. Any way you can clean that picture up a little bit and zoom in? All right. So that's the facet. Shot. This is the worst part of the surgery, I know. Trust me. Shot. And I apologize in advance. But once we get through this, the rest will be easy for you, okay? Shot. Give me an AP. You're a little bit off with the wag, but we'll come back and we'll have to fix that. So patients come to Deuk Spine Institute because they have pain for many years in their back or neck, and they're unable to get it fixed anywhere else. Or they're told wherever they live by the doctors they see, there's no cure for your pain, there's no way to get rid of it. And that's really the majority of the time. People live with chronic pain because they're told and they believe that there's no way to cure it. All right, lateral. That's a beautiful picture. You can see that the tip of the needle is right at the medial border of the pedicle, and we're about to go into the L5-S1 disc. All right, I want to try to wag it just a little bit, see if we can't find a little better view laterally. Shot. That's actually a lot better. That is absolutely perfect. I like that. Okay, so very important to get the x-ray picture done properly. All right, we're right on the herniation at 5-1. I can feel it. You feel it in your back there? Yeah? All right, just bear with me. This is the worst area. Shot. So literally we're at the herniation at 5-1, and this is going to be one of those discs that's causing her problems, I think. And shot. Unfortunately, it's so collapsed. It's going to be a challenge to get in. Let me have a guide wire. Oh, I need a new needle.
Should be back there, Crystal.
Well, let's just give me the other one. Shot. So everything's going well, okay? No, I need the needle. I'm doing something a little different. Check the other one. I felt that it was bending a little bit, so I didn't want to take any chances. Sean, are you okay? She sleepy? All right. Good. I'm glad to hear that. Sean? All right, so stylet. Everybody's anatomy is a little different on their spine. Sean? Actually, everybody's anatomy is a little different in their whole body, right? So from the skin is pretty much the same, but it's the rest of the stuff that varies, and it can vary quite a bit. Shot. So we're at 5-1, and I'm happy with the fact we're right there, but I would like to try to get a little bit more superior, a little bit further north, shot, than where we are. And so that's why I'm repositioning things. Shot. And this is a severely collapsed disc, by the way. That's why we're struggling here. We're where we need to be, but I'd like to be a little bit further along. You okay? Shot. All right, so that's about as good as it's going to get. All right. We're halfway done. We're going to get to put you to sleep soon, okay? I just need to do one more thing here. So we make a 7mm incision. And through that incision, we're going to do the entire surgery. Right now I have to gain access to the next disc at L4-5 shot. So that's what we're working on right now. You're doing very well, by the way. Are you comfortable? Shot. Can we make you more comfortable? No? Shot. Oh, she's doing fine from my standpoint. I just want to make sure she's happy, comfy. Shot. Let's get an AP. So we're about to enter the foramen at 4-5. When I say 4-5, it means L4, L5. When I say 5-1, it means L5-S1. Just for those of you watching. More medial. Is she awake enough? Yeah. So 4-5 has a disc, what we call a disc bulge. It's still a herniation. I can actually feel it right here. You can see it on the x-ray. It's kind of a little darker color. But you don't see it well on the MRI, but I can feel it right here. You awake? All right. You're doing great, Sean. I may want to reposition 5-1. I'm going to look at that one. But we're in at 4-5. I want to be able to elicit a response from her in a moment, so got to work on 5-1 a little bit. So how can we, let's get the x-ray a little bit better first. Try about a degree of wag, because we had it better and then she moved a little bit, like probably about a degree. Just try one way or the other, north or south, I don't care. That's worse. Let's go the opposite direction. Shot. Yeah, that's better. That's better. All right, now let's go back to the AP real quick. So can you keep that lateral for me? Are you comfortable? Is that a yes? All right, let's go back to a lateral view. I'm not really happy with 5-1. I'm happy with 4-5. 5-1, what have I done? Let's see. So I've slipped under. It's really a little bit of a retrolisthesis. So, you know, it's not terrible. I don't know that I can make it better than it is. That's really the issue. I think it's probably going to be as good as we're going to be able to get that, because the disc is so collapsed and the L5 is slipping backwards on the S1. You're not feeling anything down your leg, right? No. Have you felt anything go down your leg at all? Huh? No. I would love to be able to get into that disc space, just to be sure. I'm going to try one more time. I feel like I can get back here if I need to. I'm going to try one more time. So we're almost done, okay? And then we're going to put you to sleep, but I need your help just for a little bit longer, all right? I apologize. Shot. That's too high. Shot. 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 Let's get a AP, see where we are. So for those of you wondering, AP is anterior posterior, it means front back. We use really primarily two views, front, back, and side to side, to navigate to the disc that we're fixing. All right, it looks good. Let's go back to a lateral. And I'm using both front, back, and side to side pictures. These pictures are X-ray images. It's pretty standard to navigate through the spine. The spine is made up of a bunch of bones. Shot. And just going slowly and just carefully. You feel anything? Huh? AP? So the problem is the 5-1 disc is so collapsed. It's about 90% plus collapsed compared to the disc above at 4-5. Now a collapsed disc does not mean it's not painful. Collapsed disc can still be very painful. And if they're painful for the same reason that the uncollapsed disc is painful, and that is that there is a tear in the back of the disc that's causing the patient's back pain. And that same tear can cause leg pain. You feel anything? All right. Shot? Pretty much the same place I was before. So I just don't know that I can make an improvement. Pulling out all my tricks. All right. So we won't be able to do a discogram at 5-1 because your disc is, you're just guarding too much, I think, right now. Try a little bit, just one more effort here. You're not uncomfortable, are you? Good. All right. So close. Shot? That's good. So, like I said, we're not in the disc far enough to do a discogram at 5-1, so we'll just do one at 4-5. Are you comfortable? Yeah? How bad is that on a scale of 1 to 10? Give me a number. Is that where you typically get pain? All right. We're going to put you to sleep, okay? And when you wake up, we'll be done. I'm thinking about doing 4-5 first to get her nice and comfortable. All right, count from 1 to 100 in Canadian. I'm glad I got a laugh out of you. 1 to 100. Unless you want to count backwards from 100 to 1. Nice and loud so everyone can hear you. All right, so let's do a little diagram for her benefit. So at L4-5 you have a bone here. This is the number 4 bone. And then we have a disc between the L4 and the L5. Can you see this, Sean?
Yes, we
can. And then you got an L5 bone here. All right. And then you have an L5-S1 disc that's super collapsed. And then you have another bone called the tailbone or sacrum, right? We call that the sacrum. And this is number 5. So the problem she's having is she has a damage to the L4-5 disc with a tear. It's called an annular tear. That's what started all this problem. Some trauma to the disc, bending, twisting, you know, some type of sports injury, who knows what. But it happens for different reasons in different people, but it's always due to a mechanical problem where the disc is loaded with too much stress, and that causes a rip in the capsule holding the jelly in the middle of the disc. So the L5-S1 disc collapsed a long time ago. It's probably injured at least 10, 15, 20 years ago. And then the L4-5 looks more recent. So she's had 2 disc injuries, both with annular tears, and the L4-5 is a bulge, the L5-S1 is degenerated. And the L4-5 disc we just tested, it was a 7/10 pain, and that was her typical back pain. We can't test L5-S1 because I can't get the needle into the disc far enough with her being awake. She's just kind of clamping down on her bones. She's tightening up because she's not comfortable laying here. Even though she says she's comfortable, you know, nobody's really comfortable laying on an operating table. So she's a little tense, and that's in her muscles, tightening down on the bones, keeping me from accessing that L5-S1 disc. But I think we'll be able to get it when she's more asleep. So we're going to start with 4-5 shot. I'm just putting the guide wire in, and I'm going to pull the needle out. Now she doesn't have blue blood, so for all of you alien enthusiasts, this is not an alien specimen. This is a human. She has red blood like everybody else. And the blue is just the dye that we use here to stain what's called degenerated nucleus pulposus. All right, shot. I'm using the dilator now to spread open her tissues. Now, this surgery does not cause scarring except for the skin. And the reason is we're not doing an open procedure. We're not making a big incision and tearing through the muscles and removing bone and ligament out of the spine like other surgeons do. The Deuk Laser Disc Repair is unique in that it's performed endoscopically, minimally invasive, so that there's really no trauma to the tissues of your body that other surgeons create trauma when they do their surgery. Even I've created trauma when I do open surgery. So this is a atraumatic or non-traumatic type of surgery of the spine to repair, to cure back pain or neck pain. It depends on where we're operating. In this case, it's her back pain. And it's done without trauma and without bleeding. I mean, of course, you have a drop of blood or 2 drops, but that's really nothing. Open back surgery causes usually 50 to 1,000 or 2,000 milliliters of bleeding. So this is nothing. No bleeding, really. There's really no pain after the surgery. Patients take Tylenol usually, or an anti-inflammatory, sometimes a muscle relaxer shot. So minimal post-operative pain. And patients usually are on their feet within an hour of the surgery, walking around. And I didn't really talk much about the discogram itself, but when I injected the dye earlier, you could see that the dye was leaking out through a giant tear in the back of the disc into the epidural space. All right, we're going to go ahead and get started with the endoscopic part. We've got our tube going from the outside world down into the disc through the annular tear. And I can tell you the annular tear is big. I mean, the dilator went in very easily. So the dilator is what I use to spread the muscle apart by about 7 millimeters so that I can bring the tube in. If you just bring the tube in without a dilator, then you're gonna biopsy the tissues, meaning you're gonna take a piece of the muscle out, and you don't want to do that. So the dilator allows you to just spread the tissues gently and atraumatically. All right. So we're going down with our scope through the tube that's already inside her disc. There it is. You see that blue stuff? That is the nucleus pulposus, and it's stained blue because it's degenerating. That's not normal. A normal nucleus pulposus will be white. So blue stuff means that it's getting degenerated, and that's from the annular tear. And once again, Deuk Spine Institute and myself, we were the ones who discovered that annular tears create the inflammation, which degenerates the nuclear material and causes all the pain. So the annular tear by itself will not cause pain. Take it. The annular tear by itself usually heals, but what happens is the jelly called the nucleus pulposus, the blue stuff you're seeing, gets pushed out through the tear, and when it gets stuck in between the torn fibers of the annulus fibrosus, then it creates inflammation, and that inflammation causes the pain. That's highly localized. And the reason it's so localized is because the back of the disc is innervated by a nerve called the sinovertebral nerve, which carries what are called somatic afferent fibers, which nothing special about somatic afferent pain fibers except that where they project to on the brain. And they actually project to a part of the brain called the primary somatosensory cortex, which is where your body perceives very focal, localized pain. So it's not the fibers themselves that are unique. It's not so much the location of the fibers where the nerve endings, free nerve endings are, or myelinated type C fibers are. It is the actual where it goes, where it sends a signal in the brain. That's why people have back pain. They can feel, or neck pain, that they can actually feel is localized to their neck. There are other types of pain that doesn't make it to the primary somatosensory cortex. A lot of pain stops before it gets to the part of the brain that tells the person where it's coming from. It's called localized pain. A lot of pain goes to what are called subconscious areas of the brain or brainstem, and they have effects there like changing your heart rate or your respiratory rate or vasodilation or constriction or sympathetic response. So basically, pain fibers travel to different parts of the brain to have different effects. This is where spine surgery joins neurosurgery, or neurophysiology, I should say, and you know, you can either have this endoscopic surgery done, or you could have your primary somatosensory cortex removed, in which case you wouldn't feel anything in your body. Obviously, this surgery is a much better option because it's safe, it's quick, you're not operating on the brain, you're operating on a disc. We have any questions from our audience, Sean?
We do have one.
All right, before we get to that, I just want to say, for those of you who don't know, these videos are broadcast for educational purposes, and we are happy to take questions during surgery, anything to do with the spine or the field of spine, spine care, spine diagnosis, management, therapy, interventional pain management questions, surgery questions. We basically deal with any topic related to the spine, okay? Whether it's insurance or socioeconomic or surgery, whatever it is related to the spine, okay? So feel free to ask questions during surgery, and I'll do my best to answer them. We also, for those of you who don't know, we have a Deuk Spine Institute app. It's found on the iPhone and the Android. It's free. You don't have to pay for the app. Just download it, and it has tremendous amount of information you can use to better understand contemporary treatment of spine conditions like chronic back pain, which are now curable. They're curable, but you have to go to the right place, okay? We'll take that question.
Yes, one of the viewers from Facebook is wondering, is there a chance that with this patient, all of her symptoms are originating just from the L4-5 disc?
Is there a chance with this patient that all of her symptoms are originating just from the L4-5 disc? The answer is yes, there is a chance, but it's unlikely, okay? Is there a chance that you'll go home today and there'll be somebody in your house that you don't know and didn't invite? Of course, there's always a chance of these things happening, but they're unlikely and they're unexpected. So why would it be unexpected? Because the L5-S1 disc is clearly injured, and she points to that area on her physical exam. So I expect the L5-S1 disc to also be contributing based on the topography of her pain. Topography of her pain. Topography means where the patient feels the pain. And that's a very important part of our examination. All of our patients are examined very carefully to figure out where their pain is coming from. Many patients don't have pain coming from a herniated disc. They have pain coming from other structures, like the sacroiliac joints, or the piriformis muscles, or even the hip. Sometimes the hip can actually mimic as a source of back pain, okay? So it's not often, but it can. So it's my job in clinic and Deuk Spine's job to basically figure out where people's pain's coming from and allocate that pain to specific anatomical structures. And the good news is that there are a limited number of structures in the human body that can produce pain. This is one of the things I learned in neurosurgery training my first year. That was that there are very specific things that have pain fibers innervating them, and there are many things in the body that do not have pain fibers. So the things that don't have pain fibers innervating them cannot cause pain, period. Okay? And so you learn what things can cause pain and what things cannot. And at Deuk Spine Institute, we've, over the years, developed techniques for diagnosing the source of pain. And I believe the L5-S1 is contributing to her back pain. Now, I could be wrong. I certainly would be the first person to admit it if I'm wrong. But the problem is, you know, there's very strong evidence that her L5-S1 disc is causing her back pain based on her physical examination and based on the appearance of the L5-S1 disc, and also using my experience knowing that L5-S1 is the second most common cause of chronic back pain. So the problem is, if I don't treat the L5-S1, and when I could have treated it, and the patient has pain from L5-S1, guess what? She's still going to have pain when she's done and she leaves. But the problem is she lives in Canada, so of course I don't want to make her have to fly all the way back here because she's still having pain because I didn't treat the second cause of her back pain. What we found over the years, and it's a great question, fair question by the way, thank you for asking it. What I have found over the years is that the patients average 2.4 painful discs, 2.4. That's basically 2.5. So on average, people with chronic back pain that need this surgery, they have 2.5 painful discs. So it's really not much of a stretch to think that this patient who has 2 painful discs, you know, fits into that expectation based on, you know, experience and probabilities. Good question though. Trust me, if L5-S1 wasn't a problem, I'd be happy not to treat it. I don't particularly want to do another disc, but I certainly don't want my patient leaving here with pain that I should have fixed when I was here in the operating room. So yeah, and I won't be able to confirm it because I can't get into the disc space. All right. This is a huge tear, by the way. Look at this. This is all tear right at the tip of the laser. You can see the torn fibers. They used to cross across and touch each other and make a wall, a barrier. But this is a massive tear. So some kind of massive trauma, maybe a fall, maybe a car accident. I can't remember what her history was with respect to trauma, but something has caused serious avulsion, which is a ripping apart of those annular fibers. And this is just one of the biggest tears I've ever seen, to be quite honest with you, at L4-5. So whatever she did to injure this disc was substantial, just absolutely massive. We're getting close to the end of the L4-5 disc repair. You can see the posterior longitudinal ligament, kind of foraminal ligament there, where the PLL and the ligamentum flavum meet. This is all needs to be treated here. You can see the yellowish color there. That is actually hemosiderin. It's blood, like old blood from a hemorrhage. A lot of times when you tear your annulus in your disc, then you actually get trauma to the annulus, to the outer half where there's blood supply. You can tear a blood vessel. And I'm not surprised because this is the widest, biggest, one of the biggest tears I've ever seen. So she really ripped that sucker apart. And when she did, she tore some blood vessels. And those blood vessels are probably bled into this area here. And that's why we're seeing some of that discoloration of hemosiderin. But the nice thing is you can actually see it, you know, endoscopically you can see it. There's some fat, epidural fat right there. We're not really here for that. But when it gets in the way, I have to address it. Otherwise, I can't see what I'm doing. So, whoop. I just want to clean this up. This is what's keeping the disc from healing right here. Stuff like this. We've gotten rid of most of it at this point, but there's still a little left. You have another question?
None others currently.
All right, you're watching the most advanced spine surgery in the world for curing and treating herniated discs, bulging discs that cause symptoms like back pain, neck pain, thoracic pain. Thoracic, for those of you who don't know, it's the part of the spine located between your neck and your lower back. Rarely has issues that need surgery or treatment, but we have had now in the last year 10 patients that have thoracic herniations that are painful that we've done surgery on successfully with a laser endoscopic transforaminal. The first in the world in the history of spine surgery was done here at Duke Spine by myself a year ago. There is another type of endoscopic thoracic surgery called transthoracic endoscopic surgery, but it's much more risky, much more involved. It's done at the hospital. Let me have the grabber. And for that surgery, you need a cardiothoracic surgeon. You could lose your life. Your heart is moved. Your lungs are dropped. Basically, your lung is collapsed so the surgeon can do the surgery. It's a very risky surgery, very difficult to do, and you have all kinds of complications from that surgery. With the Deuk Laser Disc Repair, thoracic disc surgery, we've not had any complications. We've only done 10 patients, but it's a much safer procedure. Boy, this is all scarred in here. You can feel the scar tissue from the injury. So this didn't just happen recently. This must have happened, I don't know how long ago, but certainly not in the last few weeks. This is probably a major trauma, major fall, major something, and that just ripped this thing apart. And it's all pretty much close to the same age. You can actually tell when parts of the disc herniation are older or younger, multi-staged. Most people have multi-stage disc injuries. In other words, they had the original injury and then they had a second injury and a third and a fourth. And it's a stepwise progression. And we see that also with fractured vertebral bodies. So when people get a vertebral body fracture, like an insufficiency fracture from osteoporosis, they'll do a little bit of fracture and then it'll partially heal, and then they'll fracture it again, and then it will partially heal, and then they'll fracture it again. And so the pain is like episodic, and it comes back, and then it gets better, and then it comes back, and then it gets better. And meanwhile, the vertebral body just keeps collapsing, and collapsing more and more and more over time. So with the disc, you get a collapse as well, just like a vertebral body, but also you get scarring, a lot of scar tissue. When you fracture your vertebral body, you also get a response in the bone. It's called sclerosis, right? It's a reaction of the bone. This is all part of the tear right here. It's just huge. I'm pretty impressed. So our patient is from Canada, and I know she has family watching and friends watching the surgery. She's doing fantastic, for those of you wondering. She's asleep for this part. We keep our patients comfortable and asleep. This is actually, if the patient was not asleep, this would be painful, for a patient to go through. Stand by. This part of the disc is the part that's causing the back pain. And of course, if I'm going in there and irritating it even more using the laser, trying to take things out. I mean, just imagine a toothache, right? You go to the dentist with a bad toothache. Once they go in there and start drilling that tooth, it's going to hurt even more. So it's not uncommon then or wouldn't be too far-fetched to understand that, this is the area of her disc that's causing all of her pain. And so once I go in there with the laser and I start removing things, it's going to cause more pain for her temporarily while she's here having the surgery done. Otherwise, we would just do the surgery with the patient awake, to be honest with you. It would be a lot safer for the patient to be awake. But this would be just too painful for the patient. They wouldn't be able to tolerate it. They'd be, moving around on the table, trying to get away, just like you would in the dentist's office in the dentist's chair. You would be trying to get away from the dentist. And moving around makes it harder for the dentist to do their job, right, of drilling that cavity or doing a root canal or whatever it is they're doing to your tooth to fix the pain. So sometimes you just have to use anesthesia to make the patient comfortable while you repair an area. And this is one of those times, because this is the source of the pain and I'm operating directly on it. The problem, folks, is that a lot of doctors don't know that the disc can cause pain, back pain, neck pain. Believe it or not, if I had to guess, I don't have an exact number, but I would say at least 90% of spine surgeons, neurosurgeons, don't even know that the disc is the cause of the back pain or neck pain. They call it non-specific pain, and they basically tell the patient to go see a therapist. And they honestly don't care what kind of therapist you see. A shrink, physical therapist, massage. None of them work, by the way. You can't talk somebody out of their pain. That's ridiculous to think that. So shame on my colleagues for saying things like that to patients. Oh, go see a therapist. Go see a physical therapist, massage therapist, psychotherapist. It doesn't matter. They just don't want those patients in their offices complaining about pain. The truth is that I never kicked those patients out of my office. Instead, I listened to them and tried to figure out why they had pain, because I actually believed their pain was coming from something that was structural. And when I figured it out and found it, the annular tear, I was very happy, and we developed the Deuk Laser Disc Repair procedure to address the annular tear. We've been doing these surgeries now for 16 years here at Deuk Spine, and our average patient cure for back pain is about 98%, and the average elimination of neck pain is 98%. Same thing with leg symptoms. When patients have pain down their legs, sciatica, or neurogenic claudication from stenosis of the spine, those symptoms generally go away with the surgery. Matter of fact, I can't remember a single patient that they didn't go away, but it does happen once in a while. Maybe you'll see a patient that has the pinched nerve for so long, pain down their leg for so long, that even when I finish the surgery, they still have some leg symptoms afterwards. It's not common, again, it's very rare. But on average, 98% of leg symptoms go away with this surgery. Leg pain, numbness, tingling, weakness. For weakness and numbness, it usually takes 6 months to a year for it to go away, because the nerve has to heal more. But when it comes to pain down the legs, usually it goes away right away. All right, we're just about done with this disc. And like I said, this is one of the worst that I've seen. This is just a wide tear. Look how wide that is. From there, from one side to the other. Huge tear. But I think we've gotten what we need to. And I think she's going to be happy with the results. All right.
We have another question.
Sure.
One of the viewers on Facebook is wondering, can muscle relaxation help increase disc height in degenerated discs?
All right, so I didn't really hear the whole question. I apologize. Could you repeat it, please?
Yes, basically what the viewer's wondering is, does muscle tenseness increase disc height loss, and can muscle relaxation increase the space between the vertebrae?
Yeah, great question. The answer is yes. When your muscles are tight in your back, they're compressing down on the disc. And if the disc is already collapsed pretty badly, then they're just going to be compressing it even more. Good point. But it's interesting. So here's what's really interesting, folks. This question has brought us up for discussion. You see this disc right here that I just fixed? It's not going to cause her pain anymore. Okay, that pain will be gone. Okay? So now her muscles can relax because there's no pain there from the disc. And because of that, it won't compress the disc down anymore. Otherwise, this disc, if we didn't do the surgery and fix this, it would look like the L5-S1 disc, probably in about 5 years, you know, on average. So great point. Standby laser. You can actually see fibers of the PLL right there at about 12 o'clock. So pretty cool. All right, we're done. This was a really big one, and I feel pretty good about it. A little bit of epidural vein bleeding, no big deal, but this should heal nicely. There should be a nerve root right up here, right in that fat right there. See it? Right at 12 o'clock, I guess. That's the nerve root. It's called the dorsal root ganglion. And you can see how the herniation is so close to it. Let me get a little bit more right here. Laser? Come on. At 12 o'clock, where the fumarole is, that's the epidural space. That's where other nerves are. They're in there. We're not really wanting to go into that area. I just want to clean this stuff up. And those are starting to be fibers of the foraminal ligament that you're seeing, and that's not the problem. We're not here to do anything with the foraminal ligament. So that's not going to help the patient. I think we got it all. All right, very good. Now we're done here. Okay. Standby scope. I think she's going to be very happy with that result. And now I got the hard part. You keep her relaxed, okay? I got to try to get into L5-S1. When I say try, I really do mean that. I don't know that I'll be able to get in, but I'm going to try. And the reason I don't know that is because we're not in it right now. I was not able to get in with the needle, but a lot of times when the patient's relaxed, like sleeping, they're not in pain, they're not feeling pain, so their muscles don't tighten up, and I can actually get in there when the muscles relax. The muscles I'm talking about, folks, are the ones that run along her spine. They run along everybody's spine. They run from the tailbone all the way up to your skull. And they actually help keep your spine erect. They help with walking and standing and sitting. They keep you from falling forward, basically. So they're always kind of working, and they need to be fit and strong and active to keep your posture. But when she's laying down like this, they can either be relaxed or they can be tight. We want them relaxed. If they're relaxed, then the bones aren't being clamped down on. It's kind of like, all right, so if you're getting your tooth worked on by the dentist, right, and it hurts, and the dentist doesn't numb you up enough, and you're aware of the pain, what do you think you're going to do? You're going to clamp your jaw down. You're going to close your mouth. You're going to clamp your teeth together. Well, the spine is the same way. The muscles will tighten up with pain, and it'll clamp the bones down so I can't get inside the disc. And I want to avoid that. So our anesthesiologist is keeping the patient comfortable so she can't feel the pain. And I'm going to go for getting into that disc space at L5-S1. So this will be our best chance of doing it. Shot. Okay, so you can see the guide wires right there at the back of the disc. And once again, you know, the fact that it's so collapsed and the fact that the bone is slipping backwards, called retrolisthesis, L5 on S1, has made it really difficult to get in. But we're going to make our best effort right here. I give us a 50-50 right now, just based on what I know. Shot. Shot. No. Our anchor point held, which is good. Shot. All right. So we're right there at the back of that disc. And now it's just a matter of whether we're going to get in or not. And I have one of my patients that I did laser surgery on. He came back to clinic yesterday, and he brought a hammer for me as a joke because he watched this video and saw me hammering. And yeah, people don't like this part generally, but you know what? It's not like I enjoy it. It's absolutely necessary to do. Well, here we go. Take that. So I feel like I've got it, the dilator sitting right where I need to be, and let's see if we can get in. All right, it worked. That's good news. See how it spread the bones apart and created a white area around the tip? That's actually what we call a vacuum space phenomena. Believe it or not, there's like a negative air pressure there. If you're my age, around 50, and you grew up with what are called incandescent bulbs, you know? You remember the old bulbs when the bottom would come off, and then there's a little thing you can push on it, and then it would let the gas out. It was, or let the air in and let the gas out. It was like a sucking sound. Shot. Anyway, I've heard that sound when I get inside these discs sometimes, because there literally is a vacuum, so there's negative air pressure.
We have another question.
Yes.
A viewer from Facebook is wondering, fusion takes about 2 to 3 hours, so what's the longest a DLDR could take?
Yeah, great question. So if I was doing a fusion on this patient, it would take about 2 to 3 hours, skin to skin. The laser typically takes about 30 to 45 minutes. I would say maximum an hour. I mean, it just depends on the patient's anatomy. Some patients are like easier to do than others because they're, you know, skinnier and their spine is more posterior and the disc is just easier to get into. And then other patients can be really hard to do based on their anatomy. Please. Let me have the remover. Shot. Well, I got to see where we are. Yeah, that's good. Shot. We're in. We're in like Flynn. All right. So get the fluoro out. Yeah, that's fine. I want to turn over. Give me a second. Turnover should be quick. Today. All right. Let's try to keep it quick. So I need about 10 minutes here and we'll be ready to wake her up. Luis knows, I've already talked to him as well.
Yes, sir.
All right, folks, so we got into the bottom disc, L5-S1, and we're going to go ahead and repair this one as well. So this disc, again, was far more collapsed. The injury here is much older than the one we just did. And, you know, you can see there's some little bit of blood clot. That's due to the degenerative condition of the disc. So there's more, when you have inflammation, you get more of this bleeding. So she clearly has a lot of inflammation at this level. So you're going to have more of the little veins, capillaries bleeding. You get more bleeding from the end plates. The end plates are, do I have enough irrigation going through? All right. Yeah, you can actually see the tear right here. It's part of the herniation and degenerated disc right there. And remember, we didn't get a chance to stain this one with the blue, so don't expect to see the blue here. Actually, you're going to see more red because, like I said, the end plate will bleed, and the bleeding end plate is what causes most of that little bit of clot. Now, you're not getting a lot of bleeding, just so you know. Like if you were to pick your finger with a needle, that's about how much bleeding we're getting throughout the whole case. So it's just that it's highly magnified because of this scope. You know, we're seeing it really, really well, like zoomed in. And I'm not really interested in the end plates. I'm interested in this thing right here. This is where her pain's coming from. Everybody says, well, I mean, you got bone on bone. The disc is gone, 95%. What's causing pain? Well, this is it. And what this is the annular tear. Even though the jelly's gone, the annulus does not go away. The annular tear does not go away. It's still there. The jelly is gone because it's made out of water. And it's, like we said, under compression for a long time by the muscles tightening up, the patient being in pain, a lot of inflammation. The inflammation destroys the nucleus, but it doesn't destroy the annulus. It just ruins it, but it doesn't remove it like it would the nucleus. The inflammation will destroy the nucleus. It'll get rid of it over time. It's just that it'll take a lifetime to get rid of. That's the problem. So we're speeding it up. It's like having a piece of wood splinter in your finger. You know, your body is fighting it. That's why it's swollen and tender. I got 5 minutes. This is the area what's causing all of our pain right here. I call it the cluster of grapes because you pull your tubular retractor back and at 12 o'clock, which is medial, for those of you who know what medial is, you'll see this little cluster of tissue. And this is where all those painful nerve fibers are that are causing her pain from this level. All right. going to back it out again. And notice there's just a gap down here between the bones. There's really no nucleus left, but this is it. Look at the red and the pink. That's where all, it's called granulation tissue. Go look it up, granulation tissue. And it's full of little sensitive nerve fibers. See that? Little piece of nuclear material that it's still working on, chewing up. So back pain and neck pain and thoracic pain from a herniated disc is an inflammatory disease. It's an inflammatory disease. It is not a mechanical or structural disease. It's an inflammatory disease. And that's why most doctors have not figured it out. They have no idea. They think it's a pinched nerve that causes back pain or neck pain. That's ridiculous. Pinched nerves don't cause back or neck pain. They cause arm or leg pain. They don't cause back or neck pain. And that's why so many patients who get laminectomy or microdiscectomy and they get their nerves unpinched, they still have pain. They still have back pain and neck pain because the doctor never fixed the source of the back pain and neck pain. That's what the Deuk Laser Disc Repair does. We fix the source. And the source is the annular tear. It is the only surgery in the world, the Deuk Laser Disc Repair you're watching right now is the only surgery in the world that cures back and neck pain because it's the only surgery in the world that debrides the annular tear. Well, I hope you've enjoyed it. We're pretty much done. Dr. Pettit, we're done here. And we're getting ready to finish up. Go ahead and turn the light on. I'll show you the incision. Okay. All right. So we're taking everything out. I'm going to start by removing the scope. Okay. So this is what we do the surgery with. It's a long scope. And we're going to put that off to the side here. And then we're going to inject a little bit of medicine to reduce some of the inflammation she's having from the surgery. And then we're going to take this tube out. And let's show them the tube. Okay. Go ahead and put some pressure here. All right. Can you see the tube here, Sean?
Can.
The whole surgery is done with this tube right through the center of it. It's literally the diameter of a shake straw. So we call it the shake straw. But anyway, this goes down inside the tear. And then as I pull it back, I debride the tear and get rid of the nuclear material that's wedged in there. Watch out for the needle. And let's show you guys the actual incision. A little pressure. Let me move this stuff out of the way a little bit. All right. Can you guys see this here? The whole surgery is done with this 7mm incision. Keep some pressure on the muscle for another 2 minutes. And then we can put a Band-Aid on. EBL is 5 mils. Folks, go ahead and type up your questions, and I'll be over there in a minute to do a final interview in front of the camera and answer your questions. But go ahead and type up your questions. Surgery was successful. We got both discs fixed. I believe her back and leg pain will be gone for the rest of her life based on the surgery. That's our typical results. This is outpatient surgery. It's being done in our surgery center at a fraction of the cost of fusion surgery. And the recovery is basically 1 hour. There's no narcotic painkillers necessary for the surgery like you have to with open back surgery, laminectomy, microdiscectomy. So you can't get addicted. And the most beautiful thing in the world is we now have a cure for chronic back and neck pain. So you don't have to take narcotics. You don't have to become addicted. You don't have to transfer over to morphine or heroin later on. Yes, it's true. 70% of the heroin addicts on the street started out as people with chronic back and neck pain or joint pain who were treated by their doctors with opioids like OxyContin, oxycodone. And those people got addicted to the pain pills over, the 80s and 90s and early 2000s. And then they became unaffordable because street oxy is about $30 a pill, whereas heroin is a lot cheaper. And so now we have a country full of heroin addicts that had pain for years that went untreated. So yes, it's important. This message is important to get out. So tell all your friends, tell everyone you know that has chronic back or neck pain, come to Duke Spine Institute, we'll fix them. We want their future to be happy and normal. I'll be right there to answer questions. the way it sends the signals is that there's what's called an electrochemical gradient. I don't want to get too technical here, but an electrochemical gradient is basically a concentration gradient of ions that are charged across the membrane of the nerve. So on the outside there's a higher concentration, and on the inside there's a lower concentration of that ion, about 100-fold, 100 times less. Excuse me. And so there's something called an action potential, which is a signal that goes along the nerve, and it's created by channels that open in the membrane for just a split second, and then it allows the ions to go from one side of the membrane to the other, and that gets propagated along the surface of the nerve. We call it a depolarization, and that's because it changes the membrane potential and depolarizes it, but that's not important. But that signal transmits down the nerve through the spinal cord and up to the brain, okay? It's an electrical signal. That's how nerves communicate. And when you have inflammation going on outside the nerve, it actually affects the depolarization of the nerves, and it causes depolarizations and sensitization of the membrane of the nerve. So basically your nerve is starting to shoot like, oh my gosh, there's pain in the leg, when actually there's no pain in the leg. In other words, there's nothing in your leg that's wrong, but it feels like your leg has a problem. And that's what sciatic pain is. Sciatic pain is pain in the leg that comes from, and everybody thinks, and this is 2021, it's unfortunate, but everyone believes sciatic pain comes from a pinched nerve. It actually doesn't. It comes from an irritated nerve. And irritated nerves are just that. They're irritated, okay? It doesn't mean it's pinched. So for example, if I've got my arm right here and I grab it and I squeeze it really tight, like imagine I had Iron Man fist, I could make pain in my arm. But there's another way to make pain in my arm, and that's without squeezing it, and that's by using something like bleach, for example, or if I took a magnifying glass and I focused the sun's energy on my skin, I could burn it, and then my arm is going to hurt. So there are other ways to cause pain and stimulate nerves other than compression being squeezing, by chemical irritation. That's like bleach and light, for example, intense light or other things. There's so many things, we're not going to talk about it, but the point is that there's compression and then there's irritation. And the whole world today in spine, all the doctors, all the surgeons, all the neurologists, all the chiropractors, they all think that leg symptoms come from pressure on the nerve from a herniated disc or spinal stenosis. No. The pain down your leg actually comes from chemical irritation of the nerve, and that's what I discovered here at Duke Spine Institute, the first person in the world to announce it, broadcast it, and we've been saying it now for years. So it's irritation from inflammation that comes from the annular tear that is the cause of the leg symptoms, like pain down your leg. So this is revolutionary. This is, earth-shattering, truly earth-shattering discovery. And it changes everything because it changes the way you look at patients with back and leg pain. You can't just look at them and look at the MRI and say, I don't see a big herniation pushing on the nerve that would be causing their leg pain. I only see a small bulge or a small herniation, and so they don't need treatment. That's not true, and that's what, we're trying to change the way people understand this disease, and it is that small herniations cause symptoms too. Disc bulges cause symptoms often. It is a disc bulge or small herniation causing the patient's symptoms. If I had to take 100 patients that come to my clinic here at Duke Spine Institute every week, and I took 100 people with leg symptoms like leg pain, I guarantee you 95% of them, 95 patients out of 100, don't have significant compression of the nerve root. They don't have a crushed nerve root. What they have is an irritated nerve root with a small herniation. And the problem is that all these doctors are brushing those small herniations off, saying they're not clinically significant. There's no treatment necessary. No, there is treatment necessary. You fix that tear and that small herniation, and the patient's back and leg pain will go away, or their neck and arm pain will go away. So that's why we broadcast, is to bring the public up to the latest knowledge and understanding about spine conditions, because you're not going to get it from your doctors. You're not going to get it from textbooks. You're not going to get it anywhere else. except here. And so we're all about transparency and truth in healthcare. All right, what's our first question?
First question comes from Facebook. A viewer is wondering, Dr. Deuk, do you think there's any evidence that taking collagen supplements after DLDR would help you heal the annulus faster?
Great question. So one of the people that are watching on Facebook asked, do you think taking collagen supplements would help the annulus heal faster? So great question. I love it. You're thinking. So you might think intuitively yes, right? Because it's collagen and that's what's needed to heal the disc. So after I'm done with the laser surgery, there's literally a kind of a hole in the annulus where the jelly originally pushed out of and was wedged in there with the tear. And I used the laser to clean all this out, which you saw. And now there's beautiful tissue on the sides that's ready to grow back and actually heal. And that healing tissue is collagen. So mostly collagen. It's also elastin, and but it's probably 95% collagen. Okay. So would taking collagen supplements orally help with that process? The answer is I don't know. And I'm going to tell you why I don't know. And I've been doing this a long time. So if I don't know, trust me, nobody knows. Collagen is a protein, and all proteins get digested in your intestinal system. And they get broken down into single units called amino acids. Amino acids, what proteins are is they're basically chains of amino acids bound to each other, like long strings of beads on a chain. And there are over 20 types of amino acids, 22, and those amino acids are put in a sequence, okay, like a red bead, a green bead, an orange bead, a yellow bead, and then a blue bead, and another green, another yellow, orange. And so the sequence of those amino acids determines the nature of the protein and the function of the protein. It determines the structure and function of the protein. So collagen is one type of protein, and there's literally hundreds of thousands of different proteins, okay? Egg is a protein, meat, muscle is a protein, vegetables have protein. The point is there's all these different proteins. But when you eat it, it goes into your intestine and it gets chopped back up into the 22 different amino acids. So the only way the protein gets into your bloodstream from the intestine is by being chopped up into individual amino acids. And those amino acids are then bound to by receptors in the intestinal lining and transported across the intestinal lining into the bloodstream. What I'm getting at is, even if you eat collagen, it doesn't magically go into your body and find the disc and repair it. It actually gets chopped up into amino acids. So whether you take collagen or you take amino acids through your regular diet, eating healthy, well-balanced diet, I don't think it makes a difference, to be quite honest with you. Now, that said, I've heard of, these collagen supplements and how people are using them and their joints are feeling better. And the disc is a joint after all. So can I say to you that collagen supplements will not help you heal that disc faster? I cannot say that. Can I say to you, and I can't say that for the reason that I don't know. And nobody's ever studied that. Nobody's ever researched it. Nobody's ever looked at the outcomes and seen if there's a difference in the outcomes, patient with collagen, without. And it would be really, really, really hard to do because there are so many other factors that affect the healing of that annulus. So my advice to you would be, if you have it, take it. If it doesn't, it's not harmful to you in any other way, go ahead and take the collagen. I don't think it's going to hurt the healing of the disc, and it may improve it. But honestly, I can't say that it would for certain, and hence I wouldn't give the collagen to my patients because there are also issues with allergic reactions to collagen and other types of protein. So I wouldn't want to risk that the patient has that kind of bad reaction to collagen just for maybe they'll benefit from it.
Our next question comes from another viewer on Facebook who's wondering, is lumbar DLDR safer or more dangerous than cervical DLDR?
Great question. One of our viewers from Facebook has asked, has typed in Dr. Deukmedjian,
Is your Deuk Laser Disc Repair, that endoscopic surgery we just watched, is it safer to do in the lower back or safer to do in the neck? Is there any difference? That's a great question. So it's a complicated answer, and I always like to give the truthful answers, because the truth is, a lot of times in life we don't know the right answer. We just think we know the right answer, right? So to know the right answer, you have to have all the facts. And I don't know anybody with all the facts. I don't even have all the facts, and I'm the only one doing this, and I've been doing it for 15 years. But what I can tell you is I've done probably twice as many lumbar Deuk Laser Disc repairs as cervical, and it could be even 3 times as many. I don't know. I don't have the numbers in front of me, but the truth is that for every cervical Deuk Laser Disc repair I do about 2 lumbar. Okay, maybe 2.5 to 3. So there's more lumbar Deuk Laser Disc repairs that are done than cervical. In the 15 years I've done this surgery, I've done probably about 350 cervical Deuk Laser Disc repairs. I've done 10 thoracic, and all the rest are lumbar out of 1,300. So do the math. It's close to 1,000 lumbar and about almost 400 cervicals. Okay, and when I say 400 and 1,000, I mean patients. Remember, each patient gets about 2.5 discs repaired per patient. That's our average. It's probably closer to 2. Okay, so I've done about 2,500 discs in those 15 years in 1,300 patients. So a lot of patients have 2 discs, some have 3, some have 1. And which is safer? I've never had a complication with any of them. So I've never had a lumbar Deuk Laser Disc Repair complication. I've never had a cervical. Now, if you just look at complications, they're equal. But if you look at risk, like overall risk, the cervicals are done under general anesthesia. The lumbars are done under propofol sedation. So what's the difference? Well, general anesthesia, you use muscle relaxation. So the patient is at risk for having something called malignant hyperthermia or a complication from the anesthetic. Whereas with lumbar, they're getting propofol sedation. You can still have complications from propofol, but it's less likely. Propofol itself is very safe. But the problem with lumbar is that the patient's airway is not secure. So they could actually stop breathing during the surgery and obstruct, and then they can't move any air because their tongue is blocking their airway. Whereas with the cervical under general anesthesia, you got a tube down your throat, patient's completely out, they're not moving around, and you're breathing them on a ventilator. So in a way, the general anesthesia cases are considered safer, but in other ways they're considered more risky. So, from an anesthesia standpoint, I can't really tell you which is safer. I mean, some anesthesiologists would argue that general anesthesia is safer than an airway that's insecure, and you're putting the patient under sedation. So from an anesthesia standpoint, I'd say they're about equal. From a surgery technique, like putting a needle in and putting a tube down, I think that the cervical is more risky. And you've got the carotid artery, you got the jugular vein right here, you got the trachea and esophagus here, and I'm basically going between the two of them. Don't mean to flip you off, but I'm going like right there, okay, between them. So I'm pushing the carotid artery lateral, and I'm pushing the trachea and esophagus medial to get down to the spine. That's a lot more risky, in my opinion, than doing a lumbar. A lumbar, it's just skin, fat, muscle, and then there's a nerve root down there. You got to avoid. As long as you know what you're doing, you can avoid it pretty safely. Okay. So, from an anesthesia standpoint, the same. From a complication and outcome standpoint, over 15 years, the same. From a standpoint of which area that you're going through has more risk, it would definitely be the cervical. Okay. So that's the best I can answer the question. But the truth is that I've never had a complication with any of them. So they're all safe as long as you have somebody doing it that knows what they're doing. Yeah.
Right, next question comes from Facebook. The patient says, Dr. Deuk, I have structural deformity in my lower back and a severely degenerated discs. My doctor tells me that my neural foramen is compromised and I have arthritis in my facet joints. Is DLDR an option to unpinch the nerve at this level, L4-5?
All right. One of our viewers says they have severe degenerative disc disease, facet arthropathy, and the pinched nerve in their lower back at L4-5. They want to know if they're a candidate for laser surgery. 100% yes. We can fix your back. We can unpinch the nerve. Don't have open back surgery. Don't have a fusion. Guys and gals, the open back surgeries, I've been doing this 26 years. I've done open back surgeries for 26 years because that's what we're taught to do in our residency training programs. That's all that's known, by the way, is open surgeries. And so basically the laser surgery that I'm doing now was something I learned from some very intelligent, very advanced, skillful surgeons over in Korea and in the United States from one doctor, Dr. Anthony Young. Okay? These doctors are out-of-the-box thinkers and doers. And they taught me to think out of the box with the whole endoscopic surgery thing. And I started doing it for herniated discs to unpinch nerves. But once I was doing the surgery, I realized the patients were waking up and they had no more back pain or no more neck pain. And that's like not something you normally get in a open back surgery. So I realized I'm doing something in there that's curing their back and neck pain. And I started to think about it. What am I doing? What am I doing different that we're not doing with open surgery? And I realized what it was. It was the annular tear. It was the tear where the jelly comes out. That's the one thing we do different. Plus, of course, open back surgery, you're taking all the bone and ligament out, right? So that's destabilizing the spine even more. And then you have to fuse. So that's why there's so much fusion going on, is because the actual approach to fix the disc is causing instability that needs to be stabilized with fusion. So what I'm trying to tell all you is that if you know the fusions, the laminectomies, the microdiscectomies, they're going to be literally history. Just like phones that you have in your house, you know, the old phone, the rotary phone, they're gone. And for those of you old enough, there are these things called payphones. And you know, when I was a teenager and I went all over Europe, there were payphones everywhere. If you got to get in touch with somebody, you get on the payphone, you put $1 in quarters in there and you dial a number and you call them. They're gone. These payphones are gone. That's old technology. It's the kind of technology that has truly no purpose anymore now that we have cell phones. So think about the surgery I'm doing today, the laser surgery, is like that cell phone technology. Once you have it, you never go back to that really old technology that has so many downsides to it. Like fusion, for example. Why do you want screws and rods in your back? Why do you want a big scar, a big incision? Why do you want spinal fluid leaks and infections and cages and fractures and adjacent segment disease? Why do you want all that pain after surgery from the surgery itself? You don't. Why do you want a metal plate in your neck? You don't want a metal plate in your neck. Why do you want screws and rods and cages in your back? You don't. So the point is, all this fusions and laminectomies and microscopes that all the spine surgeons are doing around the world, except for me, that surgery is going to be gone. And it should already be gone today. But I can't fix that problem. I can't train those surgeons. They are doing what they know, what they were taught to do, and it's old technology and it needs to go. The reason I'm here is not to fix the surgeons. I'm here to fix you, the public's opinion and understanding of what's going on. So you're not a victim to their ignorance and their lack of keeping up with the most state-of-the-art technology. You know, surgeons are going to tell you that you need done what they can do. But what they can do is not what's best for you. It's bad for you. It's damaging. And it doesn't work. So that's why we're here. We're here to educate the public about the reality of getting their back and neck fixed and curing your pain, which can be cured with the right surgery, the Deuk Laser Disc Repair. All right, so you can come here. My advice to you, if you want to know if we can fix your back or neck, is upload your MRI, go to our website, www.deukspine.com. We have a free MRI review. What that means is you just put your name, your, where your pain is, and it has questions, like 15 questions. You just fill out the boxes, all right? And then submit the form and upload your MRI images. It's easy to do. If you don't know how to upload your MRI images, call our office. Call Patient Services 321-255-6670, 321-255-6670, or go to our app, Deuk Spine Institute app. It's free, download it. There's an MRI review section in there. Get your MRI in here. We look at every one of them. I personally review every MRI. And we'll tell you if we can fix your problem. I mean, first of all, we can fix your problem, but can we do it with the laser surgery? And 95% of the time, we can fix it with the laser surgery. The other 5% of the time, I can usually fix it with open surgery. So if that gives you a better idea of what the future holds, Deuk Laser Disc Repair versus all other spine surgery being done, open surgery, the future is 95% Deuk Laser Disc Repair, endoscopic surgery. Okay? What other question do we have?
Was the last one.
So our last question, we have another surgery to go do. We're going to be restarting this live stream in